Hi everyone, thanks for having me. I'm Siobhan, I'm a doctor in infectious diseases and I work in St James's Hospital at the moment. But today I'm going to present to you some data from Galway University Hospital, which was part of a kind of pilot project that I was involved in terms of doing a baseline needs assessment for development of an inclusion health service there. So I guess the project overview, so what we really wanted to look at in essence was a local or regional based needs assessment for socially excluded populations. So people experiencing homelessness, addiction, vulnerable migrants, look at the frequency and I guess their need, how much they needed to use the hospital, in what capacity they needed to use the hospital, and specifically look at unmet need in that remit and where we could try and close the gaps in terms of health equity for these groups in our locality. The kind of with the overarching view of putting together a business case for a more specific inclusion health service within the hospital itself. I guess the objectives of an inclusion health service would be to support members of marginalised groups during their inpatient admission, try to broaden the scope of healthcare delivered within a hospital for those groups, so people who might not have a GP, look at their medicines, just do a few things, think a little bit outside the box for people who might not have the same healthcare access. To bridge the gap between tertiary care and community services, and to kind of foster a harm reduction, trauma-informed approach to individuals from marginalised groups within the hospital. So very briefly about the evidence, there's an abundance of evidence that being in a marginalised or socially excluded population is bad for you. There is the largest body of evidence in this regard would exist for, I guess, homelessness and addiction, and we know that people who experience homelessness are frailer at a younger age, they have more psychiatric comorbidity, and they die much younger. And those are diseases that are we would think of as being typically socially patterned, but what's even more interesting is that there is a lot of evidence linking social exclusion and marginalisation to diseases that we wouldn't typically think to be socially patterned, such as cardiovascular disease, certain malignancy, and also changes at a cellular level in your innate immune responses. And we don't need to think back much further than the COVID-19 pandemic, where we really saw that people from lower socioeconomic classes, socially marginalised groups, were sicker and they had worse outcomes. So that's kind of a very brief overview of some social biology, but you could talk for hours about that. I guess within the catchment area of Galway University Hospital, these are kind of some of the main groups that I identified as, I guess, being the most vulnerable in terms of what we saw from an inpatient perspective. And the numbers and distribution of people within the groups will differ hugely in the west of Ireland to, say, in Dublin, where in Dublin you'll see a lot more people experiencing homelessness than in the Connacht region, so just a slightly different distribution. So the main kind of groups would have been international protection applicants and Ukrainian refugees, members of the members of the travelling and Roma community, people experiencing homelessness, people experiencing addiction, and then otherwise vulnerable is very, very broad scope, but I guess you just kind of meet a couple of people and they're extremely isolated, maybe living alone, maybe have an issue with alcohol. So a lot of, I guess people might fall into that category. But it's just people where you identify that they have a greater need or might have a gap in terms of health equity. So I'm going to bring you through some of the data and hopefully I'll explain it well as we go along. I collected it a couple of ways. So I started doing a consult service within the hospital. So collected data from that point of view, and then I also performed kind of a snapshot cross-sectional study of all the hospital admissions in the month of January 24, just to look at, in this month, this many people were admitted that have that are socially isolated or might have additional needs. I guess it's important as we go through this data that this is very much quantitative. in the initial phases of this project, and there wasn't really a kind of collaborative or qualitative data collected as part of the initial phases of this. And the reason for that really was largely because we needed numbers and cost analysis to put together a business case, and as the service develops, there'll be, I think certainly the next step would be some qualitative data. So to bring you through it then, so patients, so I guess in total identified 136 individuals during this period that would have, I suppose, met the criteria for being for needing an inclusion health service or having the potential to benefit from an inclusion health service. 84 or 62% were male, 37% female, and one individual identified as transgender. The average age in the group was 52.5 years, and the nationality varied quite widely. So I can't even read my own slides, but the majority, I guess the main nationalities are at the top, and then the spread of kind of other nationalities in the bottom pie chart there. So the majority of individuals identified would have been of Irish nationality, and the second largest group would have been Ukrainian. I looked at what social group individuals fell into. Now, like this comes with a caveat as well. We know that when we see a patient, they don't fall into an exact category. They're not distinct patient groups, and if you were to pick any individual, people might fall into a number of different categories and have a couple of layers that might increase the degree of social exclusion that they experience. So this is by no means a perfect system of doing this, but gives a rough idea of where people fall and to identify where the greatest need was. So with that in mind, 12% of the total cohort were experiencing homelessness, nearly 30% experiencing addiction. The most common substance of misuse in the hospital's catchment area would have been alcohol, with three individuals in this identified group using other substances. 17.6% I identified as having a definite overlap between homelessness and addiction, but I expect that it's a lot more than that. 16% of the group were seeking refuge from Ukraine. 10.3% were international protection applicants or otherwise vulnerable migrants. 2 individuals were in prison at the time. 9 or 6.6% were members of the travelling community or Roma community, and 6% were identified as being otherwise vulnerable or socially excluded. We looked at the reason for their most recent hospital admission, and this really was to highlight common themes within areas of acute care needs. At the time of data collection, 5 patients were currently inpatients, so I didn't include them because I didn't have complete data on them. So a very significant reason for hospital admission within the group was alcohol related, with 34% of the group, their most recent hospital admission was directly related to alcohol. And of those individuals, of the total cohort, 56 or 41.2% had a documented alcohol-related morbidity. There was significant, I guess, quite a long length of stays and a lot of bed days, so a total of 654 bed days used by those 46 individuals for that alcohol-related admission, giving a kind of rough bed day cost to the hospital of €829,272. So I don't want the cost analysis to come across as a blame game. You know, they cost us that amount. That's not it. It's looking at a huge need that the hospital is dealing with, that if we kind of look at how much it's costing the system, that you can try to argue for resource and monetary resource to try to reduce, for services to try to maybe reduce the need or that unmet need for the group. 10.3% were admitted with with a community-acquired respiratory infection, 5% with an acute infection of another kind, 4.4% with an uncontrolled chronic disease. I excluded alcohol misuse disorders from that and analysed that separately. So these might be people coming in with recurrent asthma attacks if they can't access or can't maybe afford to get inhalers, or just exacerbating their disease. 8% were admitted as a result of an underlying infectious disease. 2.2% with a psychiatric or related admission, 2.9% had a quote-unquote social admission, and then 32%, so I suppose the largest or like second largest amount with kind of other things. So that might be like an acute heart attack or a surgical reason or a cancer-related admission. If we look specifically at hospital utilisation within the group, the total bed days used, so by the 136 patients over the past 5 years, was 6,383 bed days. I analysed people who had a cancer diagnosis separately, because those people will have a lot of, you go to the hospital a lot for various appointments, so I think that would kind of, and their scheduled appointments rather than episodes of unscheduled care. So of those individuals who did not have a cancer diagnosis at the time, over 5,000 bed days were used in the preceding 5 years. When we look at, if you look at any HSE metrics for, I guess, service development or service evaluation in this context, so what's two of the KPIs are whether an individual is readmitted within 30 days or whether they have represents within 30 days or has an unscheduled readmission within 30 days. So within this group there was 15% had an unscheduled readmission, and 9.6% had an unscheduled 15% had an unscheduled representation, and 9.6% had an unscheduled readmission to the hospital. And what this can sometimes demonstrate is that when we're discharging people, we're not discharging them with a maybe very sound plan that helps them stay in the community and that they're linked in with what they need. If we look at some delayed discharge data, so again, the majority of delays within the group would have been seeking, particularly in the Galway cohort, would have been seeking accommodation for individuals experiencing homelessness, because there are next to a fraction of the homeless services in the West compared to what is in Dublin. So we did a cost analysis on that. So the total bed days used as a result of a delay for the individual's most recent admission episode was 275 bed days, working out as an approximate cost of €348,700. So I think for people who are socially excluded or are part of a marginalised group, the West of Ireland does experience some really unique challenges. The first being the geographical breadth and the geographical complexity of the region. The distance required to travel from the north of Donegal down to Galway University Hospital for your cardiology appointment or respiratory or whatever you're having yourself is very different to getting the Lewis from one side of the city to the other. It's a 5-hour journey. If you're an international protection applicant, it'll cost you 100% of your weekly allowance. So public health infrastructure and the health infrastructure design in the West of Ireland is very challenging and complex for people who don't have easy access to their own transport. Secondly, there's very limited homeless services and accommodation in the West of Ireland certainly compared to Dublin. I don't have experience of Cork, so maybe if there is anyone that can shed light on that. And people come from far and wide to Galway University Hospital because it's the largest centre. So you might find that you're trying to house people from multiple county councils around the region, and the system is set up that you physically cannot do that. So sometimes people would just be getting a bus to the unknown, and you don't know that they're safety netted in the community in the way that they need to be. I guess a lack of primary care infrastructure. GPs are full. There is not enough GPs in the country to take on the number of people and the complex medical needs that they have. I think the infrastructure of addiction and alcohol services is quite challenging for people, and and should really try to encourage more of kind of an insertive engagement model rather than relying on that individual having to demonstrate quite a lot of individual agency to attend a service. And then I think, which has been extensively discussed this morning already, around kind of migrant support and translation services. So thank you very much. I think the way forward for the service next would be definitely a collaborative approach in terms of what service users would think they need from the hospital, in terms of having a better experience there and being able to, I guess, close some of their own health gaps and their own concerns. Thank you very much.